Welcome everybody to the SVS SOOVC webinar on outpatient surgery, vascular surgery. I'm Cliff Sales. I'm going to serve as the moderator tonight. With us tonight, we have Anil Hingorani from Brooklyn, Rob Molnar from Michigan, and Ellen Derrick from Seattle. We all have experience in the outpatient arena, and we're going to have 3 talks, and we will then turn it over for questions. The SOOVC is the section on outpatient office vascular care. That's the acronym. As many of you know, the explosion in outpatient vascular care is huge. There are currently 750 office-based labs in the country and over 5,500 ASCs in the country, with the volume growing at a rate of approximately 7% per year. It's a very important topic. The SVS realizes the importance of it, hence the meeting tonight, hence the section and the attention that it's going to receive at the VAM in August. So without further delay, I'd like to introduce Anil Hingorani, who you all know from Brooklyn, who's going to talk to us about the accreditation in OBLs. Anil? Anil, can you hear it? You're muted, Anil.
Can you hear me now?
Now we can, yeah.
Okay, sorry about that. I'm just going to go back to the beginning of the talk, but again, I want to thank the SOOVC for setting this up, and I agree with Dr. Sales. This is a very important topic, a very timely topic, especially some of the recent articles that have been sent, some of the comments that have been sent out about OBL and care in the OBL. I'm going to be focusing my talk on accreditation because I think this is an important component of what we do. To try to make certain that patients are having safe care, adequate care, and care that we would want to render to our families. So again, we're going to be looking at accreditation for the OBL, pearls and pitfalls. I have nothing to declare. So office-based surgery really started in Phoenix, Arizona 50 years ago with a group of anesthesiologists. And for vascular, the big turning point was in 2008 when Medicare started allowing reimbursement for vascular procedures in the office-based setting. And this allowed the whole creation of this field for vascular surgeons. What is office-based surgery? Well, we don't have necessarily a discrete definition. It does vary from state to state. For New York State, the definition of an ambulatory care service for a procedure done in an ASC is any surgical or other invasive procedure requiring general anesthesia or moderate sedation, including any type of liposuctions not performed in the hospital. This is just a quote from a while ago, but this is some of the common sightings in the lay press. You are likely to get your next surgical operation in your doctor's office, and you may be putting your life online as a result. These types of reports in the public led to a moratorium a couple of years ago in Florida, and in 2000, for office-based surgery after they had a series of 5 deaths and 9 injuries. And this helped focus nationally the problem that we were having with procedures that were being done when they were not necessarily accredited, or the accreditation process varied from state to state. So do you need accreditation? Well, unfortunately, it varies from state to state. For New York State, it's a state requirement for any procedure that requires either moderate sedation or deep sedation. If you have no sedation, it's not required. For New York, you have to have not only an operating room, a recovery room, utility room, a business office, 2 bathrooms, a waiting area, and approximately 2,500 square feet. This can be fairly costly. We estimate that it probably costs between $2 to $3 million to get started with an OBL here in New York City. There are some variables depending if you lease the property or buy the property, what type of equipment you get, but you do have to account that you have to have a negative cash flow for the first 5 months. For New York State to be accredited, you can be accredited by one of 3 accrediting boards: JACO, which we're all familiar with, the Quad ASF, or AAAHC. Accreditation is, for the OBL, is mandated in approximately half of the states. If you look at the state medical boards, however, because some states have more than one medical board, it's approximately 1/3 of medical boards require some type of accreditation process for OBLs. That means there's a lot of variability between each states, and some states don't require any accreditation, and that's as of 12 months ago. And these numbers have not been changing for the last couple of years. So there's a lot of variability, and there are a lot of states that don't have any accreditation at all. And I think that partially results in some of the variability in terms of the outcomes. Accreditation here in New York State, you have to have an MD, DO, or DPM, you have to have nursing personnel and the adequate ancillary staff, but it's very similar to what you would require in the hospital. For Quad ASF, we had a recent site survey, and we had to check off all the boxes and make certain that all the protocols were in place and make sure that all the radiation safety was in place, all the education was in place. We had about 292 items that we had to go through to make certain that we were up to date for our Quad ASF certification. What about safety? What is the safety in terms of OBLs? Are these procedures safe? Well, if you speak to the family for Joan Rivers, they would say it probably wasn't very safe to have her EGD done in what was a accredited facility. So if you have a problem in the OBL, part of that accreditation process means that you have to be reporting any complications. For New York State, where I am, you have to report deaths, any death within 30 days, irrespective of whether or not it's related to the procedure, any unplanned transfer to the hospital, and any unscheduled hospitalizations within 72 hours. You have to fill out a form, which originally was a paper form that you had to mail in and reserve and get a receipt saying that you had sent in such and such forms, but now of course it's online. Here we can see that in this paper that OBLs are rapidly expanding. Again, what Dr. Sales was saying, that in this particular paper from 2015, in their data set, office-based procedures had increased 50-fold, while inpatient procedures for lower extremity angioplasties is steadily decreasing. In fact, a couple of years ago, we actually had, when we looked overall across the US, we actually crossed the line where ambulatory procedures for lower extremity revascularizations became more common than inpatient procedures. So that really attests to that more and more procedures are being performed in the office-based and the ASC setting as compared to a hospital setting. In this paper from Dr. Jain, again from 2014, helping address the safety and the satisfaction in his series of 6,400 patients, they found fairly good results with fairly good satisfaction of the patients. Peter Lin also looked at his series and published this in 2016. And again, in their 5,000 procedures, they had fairly good results. And even in the cardiology literature, this particular paper remotely looked at AV access. Again, the rates of complications were fairly low, and the patients did fairly well in terms of efficacy. So some of the advantages that we can gather from the OBL literature is that there's a high level of patient satisfaction. And for us, that drives a lot of our OBL volume. Patients who have had a procedure done in the hospital, and some of our patients who have also had a procedure done in the office, they never want to go back to the hospital just because of the red tape involved. It's much more convenient. They feel much more comfortable here in the office with the physicians and the staff that they're familiar with. For efficiency for the physician, it's much more efficient. We can get procedures done much more faster, and anyone who enters into the OBL routinely says that you don't have the downtime, it's much more efficient, you can get many more procedures done, and there's much more regulatory burden, but the independence, I think, is key. Some of the contraindications I do feel are important to look at. These are some of the contraindications that we have in our office. Our table only takes up to 350 pounds, so anybody above 350 pounds, they get done in the hospital. If they have a severe allergy to contrast material, we really don't feel comfortable doing them here. We don't have CO2 angiography here. We do duplex guided procedures, but then we go and send them to the hospital if we have a severe dye allergy. And I mean a real dye allergy. A patient who's documented to have a dye allergy, they have facial swelling, or they get anaphylaxis. Patients who are ASA4, we really don't like doing them here in the office. In general, we tend to have them done in the hospital, except for patients with end-stage renal disease. The patients on nasal cannula oxygen at home, they get done in the hospital. Once they can't lie still, even though we have an anesthesiologist here, we tend to say, let's do them in the hospital. If they're complex or long cases, we tend to say, let's do it in the hospital. We have the same type of clearances that we would have in the hospital for lower extremity angioplasties, for arterial procedures. We'll routinely do them with cardiology clearance and the basic setup that you would have in terms of basic laboratory workup. All of our patients, very often, quite frankly, are already have statins or antiplatelet agents. Originally, before we had anesthesia on board, we routinely gave our patients oral agents such as Valium and gave them Toradol. Now that we have the anesthesiologist, they take control. And quite frankly, I actually prefer having the anesthesiologist there. I like to have a person watching the monitor while I'm focusing on whatever I'm doing for the procedure itself. And if there were a problem, I like to have an extra set of hands to help me take care of whatever problem occurs. To help minimize pain, we routinely use lots of lidocaine, especially periappendiceal injection of lidocaine using ultrasound guidance for all of our punctures and prevent overdistension or of the arteries. All of our procedures we perform with ultrasound guidance, again, either venous, arterial, AV access, any procedure. All the patients have an ultrasound and have routine arterial closure devices placed. Duplex guidance is used at the end of every procedure just to make sure there's no pseudoaneurysm or a problem with the closure device. Most of our procedures in our office are, over the last 9 years, have been venous procedures. We do have about 400 procedures that were arterial. The majority of them are ASA3. We have some AV access and some other procedures. Fortunately, knock on wood, our complications have been fairly low overall, and our rates of complications, either for the arterial or the venous procedures, have been fairly low. The procedures that we don't perform here in the office, we don't perform IVC filter removals, although other offices have reported their experience with that, and we don't perform AV fistula placements here in our office. We don't perform chemoport placements or removals, as others have described them. We have not gone into that. But the other procedures listed, we do them. Other procedures that we're not doing, as of yet, we're not doing any routine stent grafts. We have stent grafts available for emergencies, for bleed or whatnot, but we don't routinely do them. We don't plan to do them. EVARs we routinely don't do here as of yet, although we're trying to enter a protocol to see whether or not we can do them on highly selected patients. And we don't do any coronary or any carotid procedures, diagnostic or therapeutic. Again, we feel that there are advantages to having the OBL in our hands. We also have an IRB associated with our OBL. The advantages of having that is we feel having a separate IRB that's certified by the Office of Health and Human Services helps us do our research, it helps monitor quality, and it helps maintain independent research for us. You still have to follow the same guidelines as the hospital. You still have to have all the protocols. You still have to go for all these courses for running an IRB and whatnot. But we do feel that having your separate IRB for us has helped us. And this is just some of the numbers that there are approximately 730 OBLs across the nation. Many of them are here in New York City, so it's very, very competitive. We have 3 ambulatory health services from 3 different institutions within 3 blocks of our OBL. So they're all separate institutions, we're all competing. It is very, very competitive. And I think that's going to spread nationwide. Here are the numbers that have been documented for the market size of OBLs since 2016. This is expected to increase by approximately 7% every year. So this is a growth industry. Patients are interested in this, and I think physicians are also interested in this. We actually suggest, because of this growth, that the SVS does need to get involved with the OBL, and I think this webinar helps focus that this is an important segment of taking care of vascular patients, we do suggest that the SVS should be involved with establishing that all the states should have some type of licensure or demand accreditation so that patients are safe. We also suggest that mini fellowships and outpatient services is important in terms of education of our trainees and people who are starting out their practices. And research in the OBL space, I think, is also very, very important. This is very, very little. As part of this process, the SVS has partnered with the ACS. The American College of Surgeons has been accrediting programs across surgery since 1992. The original ones were done in cancer, trauma, and now, of course, we have bariatrics, geriatrics, pediatrics, and breast, and some upcoming accreditation processes. For the vascular certification, that's again, a joint project between the ACS and the SVS. We started developing this in 2017. This is led by Dr. Sadawi, a former president of the SVS. He helped us bring together a group of chairs of the existing guidelines in 2017 to try to establish guidelines and standards for accrediting vascular OBLs and inpatient. Again, the purpose of this group was to help establish the standards of care in the inpatient and the outpatient setting, build the right infrastructure, and establish how do you get the data to make certain that patients' procedures are being performed safely and within the standards, and then verifying this with outside experts. There are 3 tiers to this accreditation process that the SVS and the ACS have set up. The comprehensive program, which is the inpatient setting that's taking care of everything, the tertiary care center, the quaternary care center. They can do FEVARs, they can do open thoracoabdominals, they have everything available from A to Z, all the nuts and bolts. I think we're all familiar with this. The verified is the more the community setting where they may not be able to do an open thoracoabdominal, but they're doing carotid interventions, they're doing lower extremity interventions, bypasses, open aneurysms, more of the routine stuff. The outpatient is the 3rd tier. Again, the purpose of this was to help make certain that these OBLs were meeting the standards and improve overall quality. Each one of these focus on the 5 phases of care: preoperative, perioperative, intraoperative, postoperative, and follow-up. And that's how 49 of these standards are established. It's based upon submission of cases, but it necessarily doesn't focus on the specifics as you would with an M&M, but rather the process of care. More specifically, how do you identify your complications? How do you identify the problems that you're encountering? And how do you go about fixing that and then monitoring your fixes? Why would someone want to undergo this procedure of undergoing the certification for your OBL? Well, one of the reasons is that personal satisfaction, making certain that your patients are being cared for with appropriate standards and appropriate care, I think is an important reason why you should get involved with this. Here in New York City, I think it's actually very important because you get a competitive edge over your local practitioners. For us, undergoing this process and the few centers that have undergone this pilot program already, it's been a learning process, and we've helped identify not only our strengths and weaknesses, but also it's been a team building experience. So I do think that this has some important advantages. There may be a role in the future for helping meet standard and regional requirements for the OBL in terms of certification. If there's any questions, please remember to put the questions into the chat box. Not the chat box, but the Q&A box. The chat box is disabled, and we'll try to answer as many as we can during the webinar. And I want to thank you all for participating with the webinar.
Neil, I'm going to ask you the first question. I'm going to take it from the chat box. Someone says to you, Neil, is the reason why you don't do stent grafts because of the cost?
I do think that the cost is an important component of making certain that your OBL can run efficiently. You don't want to be breaking the bank. You want to make certain that you're not going to be paying out more for the stent graft than what you're going to be getting. So yes, that's true. That's also the reason why most OBLs don't have drug-eluting technology available. That might change in the future, because I do think the prices are going to be changing as more and more stent grafts and drug-eluting products are available. I do think the prices are going to change. But yes, you do have to be careful about the amount of time, the number of stents you're putting in, and balloon, and you have to be efficient. So yes, I think having the finances work is important. Having said that, are there, if you find a lesion in the tibioperineal artery that you think is going to compromise your outcome for your SFA stent, yeah, we'll go above what we think may not be cost effective if we have to, and we have done that. We do cross the thresholds of what would be cost efficient for the sake of the patient's viability of protecting their stent that we are planning on or going to be putting in the SFA of the popliteal arteries. So yes, I think you need to keep an eye on the costs. I think you need to be efficient in terms of your time, but at the same time, I think we have them available for an emergency. If we have a problem, we're going to use it.
All right, I'll ask this to the panel. The two questions here are similar. They have to do with an ASC and an OBL and which is better, and a hybrid model too. Rob, you want to start that one?
Yeah, again, it's individualized. Certainly the OBL or the office-based lab is something that you probably have less regulation. And I think an ASC by nature is going to have more regulation involved with it. And there is various reimbursements. I'm going to go over some of that in my talk about the various reimbursements in an ASC versus an OBL. So certainly I only have experience in an OBL. I don't have an ASC. We work within a surgery center, but we do not own or operate an ASC.
I agree. I agree. I think Dr. Molnar really hit upon the points that you really have to be very careful about. There are big differences in terms of regulation and payments between each one of them, but we're also finding that mix is changing. So I think that some sites that were OBLs before in our area are actually switching to an ASC model. So I think you have to be very careful about how you plan that in terms of writing a business plan or whatnot, and what the options are within your local environment.
So here's a question about the vast majority of academic university practices do not have an OBL. What would be your advice in terms of academic OBLs, and should the centers add one to their practice? I know the attendees can't speak, but I think the folks at Duke have done that quite well, and I believe NYU has done it also here in New York. You know, I think I'll start that, and then the rest of you can chime in, but I think an OBL has nothing to do with whether it's an academic practice or a community practice. It has to do with delivering patient care and documenting and quantifying quality. So I think that there's no doubt that you can deliver care as well, if not better, and certainly at a lower cost to society and to the medical system in an OBL than you can in a hospital setting. Rob, Anil, Ellen, any of you want to chime in on that?
I would just add that, you know, I would love to see the academic centers get involved. I think, you know, it's always been a struggle. You're paying the dean tax. There's always restraints. You want to protect research time. You want to do, you know, the academic road. And I think from a financial standpoint, it offers great benefits because the efficiencies are there. If you run an efficient lab, you can actually increase your productivity. And again, that follows with reimbursement. You control your time. You control the atmosphere in which you're in. So I'd love to see that grow. And hopefully we're going to talk about that at the VAM. That's one of our sessions we're going to be talking about as well.
I agree. I think having academic centers involved with the OBL, I think would actually be a benefit. They actually have a lot of the setup to do it in terms of certification, in terms of accreditation. So I think it would be actually a fairly easy switch.
Okay. You know, in an effort to keep us on time and stop at the top of the hour, I'm going to switch over to Rob Molnar, who has a long experience in OBLs. He was actually gracious enough to having me out with Carl DeLoma was there to see their OBL. I don't know when we went. We brought a horse up, hitched it up to the post, and came and watched you a long time ago. But Rob, you want to go ahead and talk about
You bet.
the value of the OBL for patients and payers?
You bet. I'd love to, and I appreciate the opportunity. And I'd like to thank all the participants on the webinar tonight. And Anil, great talk. You hit a lot of great points. Some of the things which I'll also sort of reiterate. I'm fortunate to be a member of the Michigan Vascular Center, 10 vascular surgeons, and we started our first OBL in 2005. We opened our second in 2013. So we have been at this game for quite some time. We initially started it just for hemodialysis access reasons. In our community, the hemodialysis access care was very disjointed, very poor. So by having a one center stop to provide all those services really was elevating the standard of care. And then when CMS came in and started to give us the opportunity to do arterial work, then we opened it up to that. Thanks. So again, I'm going to talk about the values of OBLs for patients and payers and also for physicians. But I think it's really important to, when we do something like this and we see this shift into an outpatient arena for many of the procedures that are going to be done for vascular care, it's important to look at the venues that we can do those. Next slide, please. So as already mentioned, significant growth in outpatient vascular care. There's very few endovascular procedures that require inpatient stays. And there's no doubt that a large percentage of vascular care is going to be delivered on an outpatient basis. It's estimated that 70 to 80% of all vascular care might, be outpatient procedures. And so I think we have to embrace the fact that this is the way things are going to go and position ourselves to be able to provide the best care and really look at the venue where that care is provided. So there has been a dramatic shift, as Anil had mentioned, to the OBLs and the ASC, starting really with CMS decision to pay for approved procedures. Since then, CMS has also increased the number of procedures and the technology for approval of payment. So that has led to an increased shift as well. Next slide. So if we already mentioned approximately 750 OBLs, 5,500 ASCs currently, market cap was about $9 billion in 2020, estimated to be 14.5 in 2027 for that 7% growth rate that Anil had mentioned. And again, CMS has incentivized this migration. So why would they do that? Well, obviously they were doing that because they want to be able to save on cost. And the understanding would be that if the procedure could be done in a hospital setting versus an OBL or an ASC, why don't we do it in a center that can provide it at a much more cost-effective meaning? So patients, payers, regulatory bodies, they'll demand quality and value-based care. And I think it's really going to come down to payers, or at least I think that's probably an area that undoubtedly will occur. But we also as physicians have to demand quality and value-based care. Next slide. So I didn't Google this. I looked up value in the old Webster dictionary I had at home, and it said something that's regarded as desirable or worthy. So if we say desirable, what is desirable for an OBL? Obviously, we want to have patient and physician convenience and satisfaction. There's no doubt what Anil had mentioned is that patient satisfaction in OBLs and ASCs is very high. And I think it is about that sort of coming in to have a team approach, work with that patient. I mean, they come into a hospital setting, they usually have to go and check in, and they go to a pre-op holding area or a pre-cath lab holding area, and then they're handed off to multiple people, whereas they come into our OBL, and it's our dedicated staff that takes them through the whole system. And it's much more efficient. There's less turnaround. There's less repetition of questions. Everything is done really with them as the focus. And also it's desirable to have appropriate, high quality and cost-effective care. I mean, that is very desirable. And I think that's what OBLs and ASCs can provide. So worthy is defined as possessing valuable or useful qualities. So certainly cost-effective quality care to address increasing vascular disease is very worthy. And I think for patients and payers, it's very important, but as physicians, as stewards of the healthcare dollar, you know, we certainly have to pay attention to that, but this gives us some control of the variables. I cannot control the staff that I work with in the hospital from unit to unit. I can't control all the equipment I use or the imaging that I can purchase. Whereas in my office-based lab, I control all of that. And I can tell you that that culture is very important. It's a place that people like to be, and patients really enjoy that. Next slide, please. So let's talk about the money. So follow the money. Where's the money going? The buck stops there. So really, if we look at it, it does financially benefit Medicare, insurance companies, and patients. There's lower payment rates for procedures that are performed in OBLs as well as ASCs, and thus lower costs for patients with high copays. If patients have, you know, a strict Medicare and they don't have gap insurance, they could have a 20% copay. So if the price for the procedure is twice as high in a hospital setting, their copay is going to be significantly higher. It financially benefits physicians if, again, I say appropriate business plan. It does take, you're running a business. I mean, you really have to be prepared for that. There's a lot of costs involved in operating an OBL. You're responsible for your employees, your insurance costs, your overhead, the equipment. You're paying for the contrast, the IVs, the IV tubing, the heparin. You're doing it all. So your cost has to be managed. And it really makes you much more efficient and makes you manage your expenses much better. There's increased throughput without a doubt. There's increased productivity. What I can do in an OBL setting, it would take an extra 4 hours to do in a hospital setting. And time is value. Time to me is very valuable. I'm very busy. So when I get some extra time, it's got a significant value to me. Next slide, please. So this is a busy slide, and I don't think you can see my pointer. Can you? Can you see my pointer on there? I don't think you can. Anyone? You see my pointer? No. Okay, so no. I've got 4 procedures listed in the left column. So these are procedures that could be done in an outpatient hospital setting. Third column over, an OBL, an ASC, and then I also listed the fee that is allowable within the hospital system for the provider. So if we go to the first CPT code of 372211, that's an iliac stent. The outpatient hospital reimbursement is $9,907. If that same procedure is done in an OBL, that reimbursement is $4,012. So you can see why CMS had that incentive. That's nearly 60% less to do the procedure in the OBL as it is to do it in the hospital system. And obviously the hospital has higher fixed costs, so if it can be done safely, effectively, quality with the appropriate indications in an office space or an ASC, there's significant cost savings to be had. In the ASC, and these first numbers are 2020 numbers, so in the ASC in 2020, reimbursed $61.79, and if I did that procedure in the hospital, I'd get paid $519. So again, $519 versus me taking on all the risk, all the overhead, but getting paid $4,012, I got to pay for the stent, the balloons. If you can set up the business pro forma appropriately, it really makes sense if you have volume and can do that. If we look at the line below that in parentheses with the -21 after it, those are the 21 reimbursement values. So in the outpatient hospital in 21, that procedure would pay $10,543. In the OBL, the cost went down to $3,793 in 2021. ASC, it went up slightly at $62.35, and the hospital fee for the provider went down to $501. So the next one in the CPT code list I have is 37227, FEMPOP, and I included this one because it has that atherectomy, that big term that we're talking about with stenting. In the hospital outpatient arena, that reimbursement is $15,938. In the OBL, it's $14,891. So you can see that's a fairly significant reimbursement for the procedure. Again, you've got to buy the atherectomy equipment, you've got to buy the stent, you're paying for all of it, but you can see there's an incentive to doing that procedure in the office-based setting. In the ASC, it's $10,941, and that fee that I would get doing it in the hospital is $762. In 2021, the numbers right below that, outpatient hospital went up to $16,796. The OBL went down to $14,000. The ASC went up slightly to 11,287, and the provider doing it in the hospital got 732. The next one, 37228, tibial PTA or angioplasty. You got somebody with critical limb ischemia and they've got severe tibial disease. If you do that in the outpatient hospital setting, the hospital gets paid $9,907 in 2020. In the OBL, it's $5,072. Again, about 50% of the cost of providing it in the hospital to CMS or payers. In the ASC, it's $56.70, and the hospital fee, if I do it, is $570 that I take home. In 2021, cost in the outpatient hospital setting, $10,591, so it went up. In the OBL, it went down to $49.53. In the ASC, it's at $58.08, and you can see the reimbursement. If I did it in the hospital this year, it's $550. One trend you can readily see in the fee outpatient hospitals is that our fees keep going down as a physician or a provider or interventionalist doing this procedure in the hospital. Yet the opportunity to do that in an OBL or ASC is certainly there, and certainly would drive the financial benefit to somebody that can provide a good business plan and do good quality work. And then the last one that I included was the 36902, the fistula with PTA, because there's a lot of hemodialysis access work done. Outpatient hospital reimbursement, $5,198. The OBL is down at $1,334. So again, significant savings to a procedure that is done quite frequently for a lot of access dysfunction. In the ASC, it's $23.98, and if I do that in the hospital, I get paid $250. In 2021, the hospital rate's about the same. The OBL went up slightly to $13.59, the ASC at $21.56, and the fee in the outpatient hospital setting down to $243. The last line that I included there was a patient. On Medicare.gov, you can look up some of this information. The out-of-patient average cost for a patient in the hospital setting for a fistula with PTA was $1,039. The same patient having done the ACS or ASC would pay $479. So again, patients are also beneficial to having these procedures done in a lower cost arena. Can we hit the next slide, please? So I think there was one more slide. Go up one. I just want to make sure I didn't miss one. Maybe I can't control it. No, I can't. Okay, no, go to the next slide, please. So I will go to this, again, just a push for the SOOVC because it was established by the SVS. We know that there's going to be a significant increased shift in these outpatient procedures, and the venue in which they're performed is going to continue to grow. So the SOOVC was created to help navigate these changes to really enhance the care of vascular patients in the outpatient arena. And we're charged with education, advocacy, research, quality, practice, and ethics. So I'd ask you to please consider joining if you're not involved with an OBL or ASC, but you're interested. If you, even if you're not involved, somebody in your community probably is going to be involved, and it may not be you, it's a competitor. So I think it's important that we're able to discuss these things. So next slide, I think that's the end of my talk, and we'll open it up to questions. Thank you.
All right. Rob, thanks. That was perfect. I have a couple of questions centered around around atherectomies. One is by our former president, Dr. Hodgson, some others. But the atherectomy, let's just go right to the heart of it, right? I mean, that's been the hot potato in this. People are saying that people are doing atherectomy simply because they reimburse better. Someone even asked about the Modern Vascular article that I think a lot of us saw recently. I'll ask you to tie all these together. Talk about the whole issue with atherectomy. Dr. Hodgson wants to know why the difference for an outpatient hospital and OBL is minimal for atherectomy when everything else is so great. And then address the whole issue of, how do you monitor quality of care when you've got people putting an atherectomy down, not even spinning it, and then billing for an atherectomy?
Yeah, that's the part, and again, there was a slide I think I missed putting in there, but there's definitely an unscrupulous side to the equation, and certainly as physicians and as vascular surgeons, the majority of us at this webinar, our primary goal is patient care, but they have incentivized this procedure. And so people are looking at that and saying, well, atherectomy sounds good, and they'll pick the study that they want to look at that says atherectomy has significant benefit, and they'll convince themselves that atherectomy should be used very significantly in their patient population. I'm hoping that the more and more we have these procedures and the outpatient centers that are involved in registries with long-term follow-up. For example, I'm one of the centers that's involved with the VQI, and that registry has a long-term follow-up. I want to be able to look at that data. I want to see what it actually is providing. I think there'll be a lot of research. I think we should do research on that. And I think payers are going to look at that and say, okay, we're cutting that. We already saw this year the atherectomy rates cut. It went up in the hospital. And I think that's how they're going to control it. I don't believe that atherectomy is appropriate for all people for sure. I mean, we do not use it in all of our patients, but there are certain cases that you think it might be beneficial. I think it is driven by finances though. So accreditation, as Anil had talked about, I'm sort of on that bandwagon of thinking that payers are probably going to say, hey, if you're going to provide these services, we need to ensure quality, cost effectiveness, the appropriate indications. And I think some sort of accreditation or verification is probably going to be coming down the pipe.
All right, I'm going to ask all the panelists to give me one quick one-word answer to this question. Where have you found the greatest success regarding referral patterns for your vascular cases in the OBL? Ellen?
Patient-reported outcomes.
Anil?
I think that the patient satisfaction for us has been driving our OBL.
Rob?
I would agree. And a lot of times even referrals from nurses and staff within the hospital.
Okay. I think one of my one of my greatest disappointments with the whole system is, you know, I had a patient who walked in today, a 35-year-old woman who had varicose veins on her ankle, and she was at some place. They put in bilateral iliac stents, did bilateral RF ablations and phlebectomies. I don't know what they did phlebectomies on. She showed me her legs, pictures beforehand, and I'm just curious as to, I'm sure everyone sees that, but what is there any recourse when we see that sort of stuff? Rob, Anil, Ellen?
I'm committed to you, Anil.
I'm sorry, we have the same sort of problems, and we've had some disastrous complications as a result of some of these procedures being done in our local neighborhood, where patients have not only suffered but have died. So we have worked with our hospital to try to see what can be done to put a stop to some of this stuff that's going on. That we routinely see patients who have palpable pedal pulses who are getting angioplasties for leg pain. You can't make this stuff up in our neighborhood, and I think patients suffer. So we've been trying to work with our hospital, especially with these complications that occur when they come into the emergency room, and when they're egregious, we do take it up to the Department of Health.
That would be great if that mattered. Does anybody want to comment on the article from Modern Vascular before we move on to Ellen's talk?
I think we're going to see more of this type of spotlight on the abuses and on, you know, the nefarious characters that might be out there. We've seen enough, and I think that's going to drive. The states, I think, are looking at ways to regulate this more. As Anil had said, some states do some regulation, some states it's the wild, wild west, and there's no oversight whatsoever. So I think that type of publicity is probably good because it needs to call out bad behavior, but I'd like to see a better mechanism whereby patients that we note have been harmed can be referred into, you know, state medical society for investigation.
And Dr. Blevia had an answer to, I think, Dr. Hodgson's question. Many of you know John Blevia. He's very much involved in the outpatient center. He's part of OEIS. He says that the reimbursement rates for atherectomy are tightly calculated at the RUC CMS level, And the reason why they're higher for atherectomy is that it reflects the higher expenses in the office. Okay, so that said, we've cleared the question board. So someone else just put one up. But I'm gonna let Ellen talk. And basically Ellen's it's more of a personal talk about why she did it, why she went in and opened up an ASC.
I'm using my cell phone here in the office after a really nice day, very busy day. Thank you for taking the time to listen to me share my story. And I just want to let you know that sitting before you, I'm 45, my birthday is July 4th, and I'll be 46 this weekend. I never thought in a million years that I would be at this place in my career, much less my life. Both of my grandfathers were respective chiefs of surgery in the department down at the Texas Medical Center. Friends with DeBakey, a long-standing surgical history. I started my training in Texas. I followed my first husband out to Seattle, still recovering from the move from Texas to Seattle. It's been a long time. I got very interested in population health and worked with a man named David Flum on SCOPE and VI SCOPE, which some of you may recall. For a little bit, we were right there with VQI, and now VQI has really taken its course. And if you ask me as a young surgeon, well, I'm middle now, what I would be doing, I would be in a busy hospital practice, doing patient-reported outcomes. I'd be researching, on the track to be head of the Department of Surgery. And then a little thing called life, just got me right there around 40 years old. And I lost a child. Oh, it was awful. Had emergency surgery. I had an injury in the operating room from the surgeon. I was severely burnt out, really burnt out. And so we can go to the next slide. And around 40 years old, and on the next slide, which looks like you guys are seeing already, I'll advance it on my computer. Burnout is real. And I've served on the American College of Surgeons on the Board of Governors, specifically for the burnout committee. I've read a lot about it. I've published on it. And burnout is real, but it's something we don't talk about, like ever. Maybe it's because it's feelings or emotions, whatever. It's just not what we talk about. But it's real. And I have a copy of the little article that came out last month. And what I like about this is that when they talk about 8% of us as a population of vascular surgeons that took the time to fill out the survey report suicidal ideation. And, it's a real thing. And I was so burnt out and miserable when I was 40 years old. I thought, man, I'm just going to quit everything, and I had been on a big grant. I mean, I was done. I'd had enough. But I was walking to get a donut, my favorite food. And I asked myself, would I be willing to volunteer as a surgeon? And I was like, yeah, sure. Yeah, I'll volunteer. So I realized at that moment on the way for the donut that I wasn't ready to retire as a vascular surgeon, but I had to change the paradigm. Absolutely had to change it. And so step one was I sold out my shares in my group. I was offered some other opportunities in the Seattle area, some really fancy opportunities, but I had to do a real gut check. And we can go to the next slide. And this is my next little moment here, and this little cherry blossom comes from Seattle periodically gets snowed in. And unlike our East Coast sisters and brothers, we do not know how to live with the snow, so we wait for cherry blossoms. But I was basically in a desert of my profession and my personal life, and I remembered this little quotation from The Little Prince, a wonderful little book written in French, that in every desert, there hides a well. So we can go to the next slide. There I am, probably 5 or 4, 3, who knows, with my great-grandfather. And when I did my gut check, I asked myself, what would it take for me to stay in practice and to be satisfied and to feel like I could serve my patients the way I wanted to serve and be the boss? Being the boss was really important to me, And so I thought back to my family, and that's my great-grandfather. And we have a ranch in Texas called Box Bar. And he used to ride the trails to get the cattle to sell them in New Mexico. We can go to the next slide. These are the women in my family. Now I know for sure I'm in the 4th grade with that little corsage for Easter that my dad gave me. And you'll see on my right side is the oldest woman in the photo, and that's my great-grandmother. And these two folks ran the Box Bar Ranch. My great-grandfather would get on the horse, take the cattle, but she would run all the operations, run everything, just head of the universe. And they survived and have a thriving ranch, and the ranch is still working today. We can go to the next slide. Therefore, I decided, very bold at this time, okay? This was 5 or 6 years ago, very bold. I decided to make my own practice, build an ASC, and I named it Box Bar Vascular. I figured if those two folks could run a ranch and do all the work that it took to run a successful ranch, I could figure out how to build and run a practice solo. So we can go to the next line. There you go. And this is like an elongated photo, but that is a real branding iron, okay? This is my recovery room, has a fireplace, right? And the stretchers line up, and, we serve them little treats and homemade cookies, and I could tell you all about that because it is exciting to be in charge of a patient's care experience. It is so exciting, and so it allows you all these touches. But that is my family's branding iron. That is the Box Bar. And we can go to the next slide. And there you go. And I'm just going to say that this is a picture of myself, our anesthesiologist, and my first MA. She no longer works here. I now have 10 people working for me, which is great. And we've just signed a lease for more space. But this was our very first quad ASF case. And so, I shared with you the beginning, the legitimate burnout, the change, I had to change directions, and no BS. It is true grit, okay, to go from 0 to running, building, developing your own ASC. I think the hardest thing for me was I was always used to being an expert or top in my class, or however you want to say it. And then coming to build a business and run a practice, which there was no class for, there wasn't the group that we hope you would love to join and be with us. There was nothing, and, you just had to figure it out. So this was a really exciting day to become certified for anesthesia in my office. And we took a picture, and then I'll end on our last slide. Next slide, please. So this is me and my family in London, having a great time. And this is one of the nice side effects when you're in control and you're in charge. It turns out, vacation is really hard when you own the shop, but you can still do it when you want it. So thank you very much, and I'm open to any questions.
All right, Ellen, someone says that they love your story. Why did you choose an ASC over an OBL in Seattle?
Well, there was an OBL just down the block, but not an ASC.
There you go.
From a competitive standpoint, I thought this would be a great first thing to start. And I really wanted to offer anesthesia in the office. And so this, because I felt like if I could be certified to do anesthesia and to do minor surgeries in the office, the OBL would be much easier to add on.
Kind of the McDonald's Burger King answer, right? So do any of us have, I do not, but do any of the panelists have experience with pelvic congestion syndrome?
I do not treat pelvic congestion syndrome, so I really couldn't speak to that.
I don't have any experience with that in the OBL setting, but I am hearing others that are having problems with getting insurance authorization for these procedures, in as much that the insurance policies in the outpatient setting for defining pelvic congestion syndrome and defining when you should treat it and how you should treat it are quite varied, I guess I should put it, to put it delicately. Some believe in it and some say that it doesn't exist. So what I'm hearing from people who are trying to do it in the outpatient setting and the OBL and the ASC setting is that they have to work on each individual insurance carrier in terms of what policy they have and whether or not, what the criteria for diagnosis would be and what options for treatment they would be able to render. So as you know, there are some people who just use ultrasound to diagnose it, and there's some people who are doing angiography to diagnose it, and there's some people who are doing MRV, CTVs, etc. So as there are surgeons who have had different ways of diagnosing and treating this, the insurance carriers are following it also. But from what I'm hearing, you have to work with each individual insurance carrier to figure out what you're going to be able to do on each individual case. So it's fairly heterogeneous and difficult so far.
Does anyone do UFEs? Uterine fibroids?
Do not.
All right,
No.
so I think I'm going to take one of these questions and run with it to kind of end. It's a great ending that Dr. Schutz has kind of put to us. If each of you had, you know, a succinct piece of advice to people who don't have an OBL but want to do it, what would you tell them?
I'll start with that. I would say come and participate in the VAM meeting in our 2-hour session. We talk a lot about just fundamentals. We talk about business pro forma. We talk about cases not to do. And I think you can interact them with a lot of people that have a lot of experience in that arena. So again, that's what we're going to try to do with the SOOVC is try to increase the exposure, try to increase the educational content, and provide opportunities for people to either learn more, or why reinvent the wheel? Why don't you learn from people that have done it?
So Rob's answer to that question is come to VAM. Anil, you have
I think that's not only an important part, but also joining the SOOVC as a section of the SVS. There's a lot of discussions going on about some of those very critical issues. You have to make it financially work. You have to avoid the cases that you should not be doing. And you're not going to necessarily know that when in the hospital where we're all trained, we're trained to do A to Z. Well, you shouldn't be doing A to Z in the OBL. You need to be more focused and you need to be more efficient. And you also need to, again, provide the best quality care that you can in the OBL. So I do think that talking to others, we actually hired a professional person who does this, who sets up OBLs, and they were instrumental in helping us set up our protocols and helping us get accredited, avoiding some of the pitfalls, and it really made a big difference to have someone help us through this process.
great. Thanks, Anil. That's perfect. Ellen, you want to chime in? What one piece of
Sure.
advice do you give to someone who doesn't have an OBL but wants to get into it?
Make a business plan and prepare. Ask yourself what you're going to do in the hard times. For example, shutting down from COVID. You know, business plan, super important. How are you going to handle the finances, and what are you going to do when you're responsible for everybody and you have a slow month?
Okay, so I'll take the moderator's prerogative and end this, and I'll say that I think that the best piece of advice I would give people who want to get into an OBL is, first of all, take stock of who you are and what you do well, what you don't do well, understand what you don't do well, understand that you're operating on an island when you're in an OBL. You don't have the backup that you're used to doing. It doesn't mean that you shouldn't be doing things that you can do, but understand what the ramifications are and what your bailouts are. I think that's critical. I think you need to surround yourself with really, really talented people. And by that, I mean nurses and administrators. And probably the best piece of advice I could give is you have to have a nurse who understands what sickness means. They need to know before you do when a patient's in trouble. And a lot of nurses really have that sixth sense, and that's critical for you to be around people like that. So I think that those are really some of the keys to the success. And then I would tell you to do exactly what I did. I mean, I was lucky enough to have Rob as a mentor, and he, said, him and Carla said, come out, spend a couple of days here and see. And I think that's helpful, to talk to people who've done it, understand, what it's about. So on that note, I'll let Rob close since he's the chair of the committee. And this is his brainchild.
Well, thanks again, everyone, for participating. Thanks, Cliff, for moderating. Anil, Ellen, great talks. Appreciate it. Again, we want to be available to the SVS members. Please join the section if we can help in any way. We need the feedback so that we can, promote and put the educational pieces together, put the advocacy together. And we're going to have some real frank discussions going on across this country over the next few years as this explosion in the outpatient arena occurs. So I hope you engage on this with us. Help us. We need more people all the time to sort of, pull the oars in the same direction. But I think SVS as a group and the SOOVC as a group should really be addressing these critical issues that we've addressed tonight. So thank you, everyone, and have a good evening. Hopefully see some of you at VAM.